So I would like to introduce all of you all to Dr. David Williams, who is the Florence and Laura Norman Professor of Public Health at Harvard, T.H. Chan School of Public Health, and Professor of African and African American Studies and Sociology at Harvard. His presentation is entitled A Matter of Life or Death, Social Inequities in Health and What We Can Do About Them.
It's really good to be here today. I thank Dr. Belcher for her kind words of introduction and for the invitation to participate in this really important gathering. I have learned a lot and have been inspired by the speakers who have gone before and what they point out to this relatively youthful generation of researchers. There's a lot of work to be done, and we have high expectations of the difference that you can make as you bring your energies to address these intractable social problems where the biggest need is political will to do it. We know what to do. We know what will work. Our biggest need is political will and people who have a vision and commitment to make a difference to improve the lives of all. So I'm thrilled to be here with you today. A matter of life or death. So I want to give an overview of some of the challenges we face in the United States in terms of health. And the first big problem I want to talk about is that as a nation, we're all doing badly. We spend more money on medical care than any country in the world. According to the World Bank, half of the money spent on medical care worldwide annually is spent in the United States. We are less than 6% of the world's population, consume 1/2 of its medical resources, and rank near the bottom of the industrialized world on health. So not only are we doing poorly, but we're losing ground over time. So in 1980, we were 11th in the world on life expectancy. In 2014, we are 35th in the world. Countries like South Korea, Greece, Cyprus, Cuba, and Lebanon have higher life expectancy than the United States. And if you think it's just because the minorities are doing badly, we've had a minority presentation. I'm going to give another one talking about minorities as well. If white America were a country, in 2014, it would rank 34th in the world on life expectancy. If black America were a country, it would rank 96th in the world on life expectancy, illustrating the inequality, but illustrating that even whites are doing poorly. There was a recent Institute of Medicine, or National Academy of Medicine, the new title, report a year and a half ago that showed even the college-educated white Americans with insurance and with good health behaviors are doing more poorly than their peers in Western Europe. So even the best of Americans are not achieving a level of health that is possible in the world today. Here is the data where we rank compared to other countries, 35th in the world. Here is where blacks and whites would look if they were separate countries. So the larger context of inequalities means that as a nation, we need to come together and figure out what are we going to do to improve the health of all, because all of us are far less healthy than we could or should be. And then we have some groups that are so much further behind, we need to think of what are the additional strategies we need to do to bring them up to speed. What are the drivers of these health problems? One of them globally is socioeconomic status. I abbreviate it as SES, typically captured by income, education, occupational status. Wealth is the largest predictor of variations in health in the world. In virtually every society in the world where we have data, persons with higher income, education, occupational status have better health than those at low levels of those socioeconomic resources. Doesn't matter whether the country has a national health service or not. It's true globally. It's true in Western Europe. It's true in Asia. It's true everywhere. Socioeconomic status. And as a sociologist, I learned that socioeconomic status doesn't just predict health. It predicts virtually everything in society. So let's take something that we may think of as far removed from health, but really isn't. The SAT test, the Scholastic Aptitude Test, that some are calling the Student Affluence Test, because here is national data for the United States in 2014, SAT scores by family income. Every higher level of family income, as you go from $20,000 to over $200,000, is associated with higher SAT scores. What do those tests capture, and how should we use them when they are so profoundly driven by what people have been exposed to in their socioeconomic environments? And what is true of SAT scores in the United States and elsewhere is also true of health. Here's national data for the United States from the panel study of income dynamics and showing the relative risk of overall mortality by family income. And again, you see as family income increases, mortality rates decline. And it's not a threshold effect. It's not just if you move from the poor or from the middle class, but every single higher level of income, researchers call it the gradient effect, is a powerful driver of worsening health. So if socioeconomic status is a powerful predictor of health in the U.S. and elsewhere, and there are large racial ethnic differences in health, you see where I'm going, then it's not a surprise that there are large racial differences in health. The racial differences in socioeconomic status are much larger than people think they are. So here is national data for the United States Bureau of Census, and I'm just putting it in a way that you can't miss the point. For every dollar of household income that white households had in 2013, Latinos had 70 cents, Native Americans had 62 cents, African Americans had 59 cents. One of the striking things of the 59 cents for African Americans that is identical to the black-white gap in income in 1978. In 1978, that's the zenith of the gains as a result of the civil rights movement and the war on poverty. African Americans earned 59 cents for every dollar whites earned. And in 2013, African Americans earned 59 cents for every dollar whites earned. Most of my students think we've made a whole lot more progress than that. I should comment on the Asian income. Asian is the group most heavily made up of immigrants in the United States. 70% of Asians are immigrants. They have the highest level of college completion in the United States, more than twice the level of whites, for example. So they're a group that comes to the United States with high levels of social capital. Asian households also have more persons contributing to household income. So if I've shown a per capita income measure, whites have the highest level of per capita per person income. But the Asian income has to be understood within the context of the population. It also needs to be understood in the context of the heterogeneity that exists within every single racial ethnic group I have up on this chart. So although you see Asians with the highest level of household income, there are subgroups of the Asian population, the Hmong, the Laotian, and Cambodian, that have lower levels of income than African Americans and Native Americans. So paying attention to the specific community you're in and what is a specific subgroup and their history and context becomes very important in terms of understanding a group within its local context. Home ownership, a very widely used indicator of wealth, of equity, economic assets in the United States. You can see, again, dramatic variations in home ownership across various racial ethnic categories in the United States. And home ownership is one of the big indicators of wealth. If you look at overall wealth in the U.S., this is a 2014 report from the U.S. Bureau of Census. For every dollar of wealth that whites have, African Americans have 6 pennies and Latinos have 7 pennies. That's the racial gap in wealth. The racial gap in wealth today is wider than it was when President Obama took office, because as a result of the economic downturn and the housing crisis, minority households had disproportionate losses of home equity and disproportionate losses of home ownership. So when we look globally in the United States at race and health, there are 2 patterns that we see. The groups that have been in the United States for a long time, characterized by economic exploitation, social stigmatization, and geographic marginalization, whether it's residential segregation in urban areas or the isolation of Native American communities. Blacks, African Americans, American Indians, Alaska Natives, and Native Hawaiians and Pacific Islanders. We have more data on blacks, but the patterns for Native Americans and for Native Hawaiians and Pacific Islanders is exactly the same. These groups have much worse health than the U.S. average. Immigrant groups tend to have better health than the U.S. average. In fact, across the board, if we look at the most widely, readily available indicators of health, overall mortality or infant mortality, we see a fascinating phenomenon that immigrants of all racial ethnic groups have better health than their native-born counterparts. White immigrants have better health than whites born in the U.S. Black immigrants have better health than blacks born in the U.S. Asian immigrants have better health than Asians born in the U.S. Latino immigrants have better health than Latinos born in the U.S. Across the board, there's a healthy immigrant effect. The tragedy is, the longer immigrants stay in the United States, the worse their health becomes. So we see this dramatic decline in health for immigrants as they stay in the U.S. And I have lots of examples of that, but in the interest of time, I'm not going to show that data today. Minorities not only have higher death rates, they get sick at younger ages, they have more severe illness, and they die sooner than whites. I'll give you a couple examples. The cardio study, a foresight study of the development of cardiovascular disease in young African Americans and whites in the United States finds that a 20-year follow-up study of 18 to 30-year-old young people at baseline, incident heart failure before the age of 50 was 20 times more common in blacks than whites. I didn't say twice as common, I didn't say 5 times as common, 20 times more common, reflecting the dramatic earlier onset of disease. Arlene Geronimus has coined the term weathering. Other researchers use the term accelerated aging or premature aging to characterize the profile that we see for African Americans. African Americans and other minorities, there's more research on African Americans, but we believe it to be true for other disadvantaged groups, are literally physiologically aging more rapidly than whites are in this country, although we live in the same society. In other words, the cumulative exposure to stress, psychological, social, physical, chemical, it's taken its toll. And the notion of weathering, imagine a drop of water falling from the rooftop of this building to the concrete sidewalk below. If water falls today, it's not a big deal. But if day in, day out, week in, week out, month in, month out, there's a steady, constant drip, drip, drip of water, the sidewalk below becomes weathered. It becomes eroded. It becomes compromised by the chronic, ongoing assault of adversity. The same is true for the living conditions and the exposure to stresses of disadvantaged minority populations, where their chronological age is capturing not just how long they have lived, but it's also capturing how long they have been exposed to bad environmental conditions and therefore how physiologically compromised they are because of such exposures. I'll give you one example. A study of middle-aged African American and white women, they're all the same age, using telomere length as a measure of biological aging. This is capturing biological aging at the level of the cell, finds at the same chronological age, black women have accelerated aging of 7.5 years. They're 7.5 years older physiologically compared to their white counterparts who are the same chronological age. Racial disparities in health persist. For blacks and whites, we have data going back to 1950 nationally from the officially reported federal statistics. And here is life expectancy at birth, 1950 to the present. And there's good news and bad news in the data. The good news is, in 1950, there was an 8-year gap in life expectancy. In 2010, there's a 4-year gap. So we've cut the gap in half. That is progress, and you can see over time, steady increases in life expectancy for both racial populations. That is good news. That needs to be celebrated. We need to accelerate what has been done, but this is good news. The bad news is there is still a 4-year gap in life expectancy. A 4-year gap is large. If we froze the life expectancy of whites and had the life expectancy of African Americans improve at an average rate at which life expectancy has improved in the U.S. overall for the last decade, it will take 30 years to close that 4-year gap. In fact, you can see those numbers. Look at the life expectancy of whites in 1950, 69.1 years, life expectancy at birth. How long did it take for African Americans to equal the health that whites had in 1950? 1990, 40 years later, is when blacks caught up to the health that whites had in 1950. So these are huge differences that we're seeing. When I started my career, most researchers thought that the racial differences in health were exclusively a function of racial differences in socioeconomic status. So if you look at minorities and whites at the same level of income and education, there would in fact be no racial differences in health. We now know that life is more complicated than that. Let me show you national data for the United States. Life expectancy at age 25. At age 25, the average white person will live 5 years longer than the average African American. Here is the power of socioeconomic status. If we look within whites, by education, whites with a college degree or more education live 6.4 years longer than whites who have not finished high school. Importantly, the socioeconomic gap is larger than the racial gap. That's really an important point, because as a nation, we focus almost exclusively on racial disparities in health and use racial data to reinforce negative social stereotypes, whereas if we stratify the data, we can see what some of the drivers are in a much more profound way. The same is true within African Americans, and this is true for a lot of national data. If you stratify by race and SES, the SES gaps are larger. And you can see within African Americans, 5.3-year difference between blacks with a high school, with a college degree or more education, and blacks who have not finished high school. At the same time, it's not either race or socioeconomic status, it's both. Because at every level of education, the same is true for income, there still is a racial gap. So white high school dropouts live 3.1 years longer than black high school dropouts, and the difference becomes larger as education increases. So it's even bigger, 4.2 years, among the college educated. So let's look at the best of African Americans. Blacks with a college degree or more education, life expectancy at 25, 52.3 years. They are living 4.2 years longer than their similarly educated white counterparts. And stunningly, national data for the United States, African Americans with a college degree or more education have a lower level of life expectancy than whites with a high school degree. I'm pausing so this sinks in, because this is stunning. So it says profoundly, there's something about socioeconomic status that drives health in the U.S. It doesn't matter what your race is. But it also says there's something else about race that creates an added burden that is adversely impacting health irrespective of your socioeconomic status. Why does race still matter so much? 4 reasons. We know that health is affected not only by your current socioeconomic status, but what you've been exposed to over the life course and across generations. There is growing body, there's epigenetic work now, looking at survivors of the Holocaust, for example, and seeing epigenetic effects in the survivors that is replicated in their children and makes their children more vulnerable to certain health conditions. So that's one factor. We have to take the life course into account. African American college educated individuals today are more likely to have been born low birth weight, more likely to have been born poor, more likely to have experienced deficits in access to medical care and nutrition and great exposure to adversity over the life course. And our bodies keep a record of all of the exposures we've had. Secondly, all indicators of socioeconomic status are not equivalent across race. So even when I'm looking at college education, they don't mean the same thing in different racial groups. So national data for the United States, for example, shows that compared to whites, blacks and Hispanics receive less income at every level of education. They have less wealth at similar levels of income. And they have less purchasing power. And the purchasing power differences is one of the dramatic illustrations of how life is not fair. Because the places where blacks and Latinos and Native Americans live are much worse places. But the cost of goods and services are more expensive in those places. They're inferior in quality, but higher in cost. And then discrimination, racism continues to play a role. I'll talk about 2 mechanisms of racism today. And then there's high exposure to multiple stresses. So all of these factors combine to cause this higher burden. I want to illustrate that by giving you some examples. And I want to illustrate the importance of thinking, as we think of racism, to distinguish between individual discrimination and institutional discrimination. So here's a recent audit study done of discrimination in crossing the street. The study was done in Portland, Oregon. They took 3 black males and 3 white males, dressed them similarly, put them at different intersections, and looked to see, as they intended to cross the street, is there a difference In even being able to cross the street in these United States, does your race make a difference? And yes, cars are less likely to stop, wait longer to stop when a black person is waiting to cross the street than a white person. And blacks actually wait longer simply in crossing the street. That is individual discrimination. That's what individual drivers are doing. We're in election season. There's discrimination in how long you wait to vote in this country. So here is the 2012 presidential election, national data for the United States, and you see whites on average waited 12 minutes, Native Americans 13 minutes, Asians 15 minutes, Latinos 19 minutes, African Americans 23 minutes. Those are institutional processes. There's no discrimination among the precinct workers there. But the length of time is linked to place. Where is it that you go to vote? And what are the policies and procedures and the budgeting and space constraints and local administrative procedures that leads to differential ability to vote? How many voters are being served by a polling site? How many polling sites are there to the population in different areas? And how many precincts in a given area? What's the level of staffing of a given precinct that all affects? These are a number of institutional mechanisms where the people there are just doing their job, no discrimination on their part, but they're institutional processes that operate. The same is true in life in general and in health. The most powerful institutional mechanism of racism that no one is talking about in this presidential election is residential segregation. And I include in residential segregation the forced removal and relocation of indigenous peoples as well, because these have led to the isolation and marginalization of populations from access to the ladders of opportunity in American society. Residential segregation. Researchers have noted that it was basic, Murdoch in 1944, basic to understanding racial inequality in America. John Seller, historian at Duke University, wrote a book about the origins of segregation in the U.S. South and South Africa. The book is entitled The Highest Stage of White Supremacy. And in this book, he showed that the framers of apartheid in South Africa looked across the Atlantic and saw what the U.S. had done and said, brilliant, we love it. Wonderful strategy. We will also implement it. That's where they got the ideas from us. Although we have in self-righteousness attacked them. John Searle also argued that residential segregation by race was one of the single most successful domestic policies of the 20th century in the United States, because it's beneath the radar screen, but it's a driver, or as Massey and Denton call it, the key structural factor for the perpetuation of black poverty and the missing link in efforts to understand black poverty. And you're saying, why are you talking about segregation? What does segregation have to do with anything? Well, where you live determines where you go to school and the quality of education you receive and what your SAT score is going to be. It's driven by where you live. Where you live determines access to employment opportunities. It determines the quality of housing and neighborhood environments. It determines whether it's easy or difficult to live a healthy lifestyle in your neighborhood. It actually determines, studies show, access to medical care and even the cost of pharmaceutical in the local pharmacy is linked to where you live. Here is the map showing the city of New Orleans, just as one example. One neighborhood in New Orleans, life expectancy is 55, another one is 80. A 25-year difference in life expectancy linked simply to where you live. Many public health researchers are saying for most Americans, your zip code is a stronger predictor of how long and how well you live than your genetic code, because it's such a powerful predictor of access to opportunity in society. William Julius Wilson and Robert Sampson, two great American leading sociologists, studied 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. That's what segregation has produced for us. Segregation also contributes to these large racial differences in socioeconomic status that we see. David Cutler, until recently dean of Harvard College, one of the country's leading economists, did a national study looking at blacks and whites in the United States and using fancy econometric models I cannot even fully describe. He shows, though, statistically, if you could eliminate residential segregation, you would completely erase black-white differences in income, education, and unemployment, and reduce black-white differences in single motherhoods by 2/3. I need to pause again so we can sink this point in. The point I am making here today is that racial ethnic differences in socioeconomic status and in access to resources are not random events. They didn't just emerge. They don't reflect the preferences of populations. They're not acts of God. They reflect the successful implementation of social policies that are doing exactly what they were designed to do. And we will not eliminate them if we don't get at some of these driving underlying policies that were set up to create racial inequality. There's also individual discrimination. And individual discrimination, a growing body of research indicates, also matters profoundly for health. It's a toxic stress of perceived discrimination. So several years ago, I developed the everyday discrimination scale. I developed a scale looking at major experiences of discrimination, like being stopped, physically threatened, and abused by the police, or not being hired for a job, and so forth. But I also developed the everyday discrimination scale to capture the day-to-day little indignities. Being treated with less courtesy or respect than other people, receiving poorer service than others, people acting as if they think you are not smart, or if they're afraid of you, or if they think you are dishonest. And just to illustrate the power of the findings of discrimination, I'm showing one researcher, Dr. Tenney Lewis, who was at Yale University when she did this work, currently at Emory. And every line on this study represents a different peer-reviewed publication showing the relationship between this single measure with different populations and health outcomes. So high levels of everyday discrimination predicts more rapid development and coronary artery calcification for persons followed over 5 years. It predicts higher levels of inflammation as captured by C-reactive protein. It predicts higher levels of blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. The study of the elderly followed over time. Higher levels of everyday discrimination predicts more rapid declines in cognitive functioning over time. A community sample, higher levels of everyday discrimination predicts poorer sleep. A study of the elderly followed over time. Discrimination is literally an independent risk factor for premature death. High elevated mortality risk directly linked to discrimination, adjusting for other factors. A study of black and white women, higher levels of everyday discrimination, unrelated to waist-hip circumference, unrelated waist-hip ratio, unrelated to waist circumference, unrelated to subcutaneous fat, but is a powerful predictor of visceral fat. Visceral fat is a deep fat in between your body organs that is the driver of the link between abdominal obesity and higher risk for cardiovascular disease and other outcomes. This is just an example. There are literally, I used to be able to keep up with the literature on discrimination. I can't. There's so much work now coming out globally that is telling us the same story, that discrimination is a driver of ill health. There are today studies from South Africa, New Zealand, Australia, and the United States that show when you look at racial differences in health and you adjust for income and education, there's a residual effect. When you add discrimination, you further explain that residual effect. So we now know empirically that subjective experiences of discrimination is one risk factor that accounts for that residual effect of race that we were talking about. And I just want to illustrate with the work of Jean Brody and colleagues an example of the age at which we are seeing these effects. These researchers are studying African Americans and teenage adolescents in 3 rural counties in Georgia, measures discrimination at age 16, 17, and 18, and at age 20 looks at what they call an allostatic load, physiological functioning, looking at a number of stress hormones and systolic blood pressure and inflammation and so forth. Stably high levels of discrimination as a teen is linked to allostatic load at age 20. So at age 20, we are seeing the physiological, biological effects. Discrimination has huge negative effects on mental health, predicts higher rates of depression, of other psychiatric disorders, of substance abuse. But we are finding even physiologically, at the age of 20, discrimination is adversely affecting physiological functioning. Let me also give an example of a study that raises the question of what is not just even the discrimination you personally experience, but it's discrimination in this larger environment that also has consequences. In the wake of September 11th, 2001, there was well-documented increased harassment and discrimination of Arab Americans in the United States that was quite at an elevated level for 6 months. Diane Lauderdale, a researcher, did this really classic study. She looked at birth outcomes for women in the state of California by ethnicity 6 months before September 11th compared to 6 months after. And 6 months after is a period we know when Arab American women were at greater threat collectively. And what she found for Arab American women only in the 6 months after September 11th, there were increased risk of low birth weight and giving birth to preterm infants. The same was not true for black women, white women, Native American women, Asian women, Latino women. It was true only for Arab American women. We have other studies that showed during the same period of time, there was increased levels of psychological distress and depressive symptoms among the Arab American population in the United States. But what this is showing is not only their mental health was affected, but even the health of the next generation was affected by the larger hostility that exists in the United States towards that group. And so we have to think of what it means to be an immigrant in the United States and in Arizona and in other places like that when there's such extreme hostility that is actually adversely impacting the health of these populations physiologically. What can we do? Number one, we need to provide high quality care to every client. And someone is saying, did you come all the way from Boston to tell me this no-brainer that we should develop, of course we do this. Well, in reality, it's really very hard to do. I served on the Institute of Medicine on Equal Treatment Report Committee that produced a report in 2003 that documented across virtually every therapeutic intervention in the United States, blacks and other minorities receive poorer quality care and less intensive care. It exists in academic medical centers, in community hospitals, and rural facilities. It exists everywhere. Give you one example to illustrate it. Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a patient comes into the UCLA emergency room with a long bone fracture, a broken bone in the arm or leg, does the patient's ethnicity make a difference with whether the patient gets pain medication or not? Get the picture? Patient with a broken bone, does your race, ethnicity determine whether you get pain medication? Looking at all persons treated for the prior year, you found 55% of Latinos had not received pain medication compared to 26% of non-Hispanic whites. Dr. Todd was a good researcher. He said confounding, something else. So statistically, he adjusted for the age of the patient, whether they spoke English or not, what time they showed up at the ER, how long they spent in the ER, whether they got injured on the job or not, what's the severity of the injury, did they get hospitalized. The single biggest predictor of whether a Latino patient got pain medication was the patient being Latino. And his final adjusted models, Latinos were 7.5 times less likely, when you statistically adjust for everything, it became even stronger, 7.5 times less likely to get pain medication. Dr. Todd moved to Emory University in Atlanta, repeated the same study at emergency rooms in Atlanta with black and white patients, found exactly the same thing. A black patient with a broken bone in the arm or legs, less likely to get pain medication. How on earth do we make sense of this? How is it possible that in a country with the best educated and trained workforce of healthcare providers who wake up every day and aim to do the best for their patients can nonetheless produce a pattern of care that appears to be so discriminatory? We have a large body of scientific research, and we have even more research today than at the time of the Institute of Medicine report that says when someone holds a negative stereotype about a group and you meet someone from that group, the process is automatic, it's unconscious, which means you do it without thinking, there's no intent on your part. In fact, you're unaware of the fact that you did it. You will treat that person differently. That is, you will discriminate against that person. But you will not be unaware of the fact that you did it. Now, I tell my students that I am a prejudiced person. Why? Because I'm a normal human being. And if you're a normal human being, you are prejudiced. Now, I'm not saying you're racially prejudiced. I'm saying you're prejudiced. Because every society has its in-groups and its out-groups. And all of us have been socialized with some groups being in-groups and out-groups. So this is not about white Americans. This is not about Americans. This is not about physicians. This is about how all human beings process information. We process information by using processes of social categorization, putting things into categories. The question is, based on who we are and where we were raised and what we were fed, what are the negative stereotypes in our minds. So if I may not be racially prejudiced, but if I have negative stereotypes about gay people, about fat people, about women, about old people, the same processes operate. It's a part of the human condition. Given the history of the United States, and we got a deep sense of that history of Native Americans, we have a lot of negative anti-black stereotypes, and this is work from your own Dr. Lisa Cooper, a great colleague of mine, shows that this implicit bias affects not only the actual treatment decisions, but it affects the quality of the doctor-patient relationship, even among healthcare providers who are working in safety clinics in the greater Baltimore area. Where do these negative stereotypes come from? A group of researchers have created a database of American culture. It has about 10 million words. They've put in it the literature, the books, magazines, articles, newspaper articles that the average college-educated American would read in their lifetime. The beauty of this is if we've put American culture in a database, we can now look within that database of American culture and say, when the word black occurs, what have all of us raised in this society learned to associate black with? Poor, violent, religious, lazy, cheerful, dangerous. Here's the happy Negro that dances and sings and provides entertainment from on the plantation days. When white occurs, wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, when female occurs, distant, warm, gentle, passive, male, dominant, leader, logical, strong. If you've grown up in this society, this is what you've seen. This is what you've been exposed to. This is how you've been socialized. These are things that are deeply embedded in your subconscious. These are the 10 most common terms co-occurring with black and with white. And you can see the difference. And folks, this is profound. Because what this means, that when a cop sees a young black male and overreacts because he sees him as more violent and dangerous, this is not a bad cop. This is a normal American. He's simply reflecting what he has been socialized to see, the associations he has seen over his lifetime as being raised in this culture. And one of the things we need to do long term is think of how can we fundamentally change American culture, because it's a culture that plants those seeds, and what we are looking at is the fruit of those normal associations, how they play out in normal human behavior. And unless we get at the deeper cultural things, we are not going to change anything, because people are acting on the culture. What percentage of Americans have anti-black bias? For the website of the Implicit Association Test that has tested millions of Americans, at least 70%. At least 70% of all Americans, by race, by profession, have negative anti-black biases. The only group of Americans that don't fall into the 70 to 80% range is blacks. Among blacks, it's 30%. So even 1 in 3 blacks have anti-black biases against blacks, and will do exactly the same thing, because it's not the color of your skin, it's what's in your mind and what's your socialization you have experienced. The good news, there are strategies. Diana Burgess and colleagues have a wonderful paper that looks at all of the strategies that can work to do it, and I usually recommend to people the Divine Solution. That is, Professor Divine at the University of Wisconsin-Madison has shown that you can bring multiple of these strategies that show independently to work together, put them in one program, and she has been successful in showing it can reduce implicit biases in non-black adults, where the effects are still evident 3 months later. Is the longest that has been shown in any scientific study to date. 3 months later, you have successfully reduced the bias, and it remains low 3 months later. So there are a number of strategies that are available that can be used and that are proven to be effective. We also need to recognize implicit bias, because the person who says, I will never do this, is the person who's perfectly set up to do it. Implicit.harvard.edu is a website where you can go and take the implicit association test to make you feel better. Both the researcher who developed the test, Professor Greenwald, when he took the test, he's so committed to this issue that he developed the test. When he took the test, found he had anti-black biases himself. And Professor Banaji, who manages the website at Harvard, when she first took the test, found she had anti-black biases as well. It's normal. If you are raised in this society, you're just reflecting what you've been exposed to and what American society teaches. What else do we need to do? We need to develop care that addresses the social context. As the World Health Organization asks the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? And there are models that illustrate that this can be done, but the point is we need to think differently. We need to ask questions of how can we identify not only the medical needs, but the non-medical needs that our patients have, and how can we link them to local services and resources that meet the challenges they face, which means we have to collaborate with other sectors of society beyond the medical and public health sector to other sectors. We need to connect community residents to jobs. In most American communities, the largest employer is the healthcare system. We need to do more to promote the health of our community residents by linking them and preparing them for jobs within the healthcare sector and other sectors. We can also use community health workers to provide services to link patients to supports. The Medical Legal Partnership is an example of a program like this. It's at the Boston Medical Center. Dr. Zuckerman, the head of pediatrics, developed it more than 30 years ago. A primary care provider at the Boston Medical Center can link a patient or refer a patient to a number of specialists. One of the specialists is a lawyer. The hospital has on-site lawyers there to solve the problems in the lives of their people. I spent a day at the Medical Legal Partnership when I first moved to Boston, and the director of the program told me, show me a person who's poor and I'll show you a person who has 3 or 4 legal problems that just never define them as such. But a child with asthma linked to the housing conditions in the apartment where they live will not breathe symptom-free regardless of all the medication you give that child if that child goes back to live in the same conditions. And the mother who has talked to the landlord and makes no progress, it does make a difference when a lawyer calls and say you're in violation of the housing codes of the state of Massachusetts, and if you don't fix this, we will sue you. So bringing help and lawyers on board is making a difference. The hospital actually only pays for 1 lawyer, but uses law students and has worked with several of the large legal firms in Boston that rotate all of their new attorneys through the Boston Legal Partnership. So there's a much larger team of attorneys providing care than the hospital as a safety net facility is actually paying. Another example is Health Leads. That's also born in the Boston Medical Center that uses college undergraduate volunteers. I have my undergraduate students volunteer for Health Leads. And they staff the desks of admitting units or other registration units at local hospitals and clinics, and they question people about their needs in the area of food, housing, heating, other social issues, and it's the job of that student to link that patient with the service that exists. This is the Health Leads vital signs checklist, asking people about not having enough food or if the home is unhealthy, trouble paying utility bills, and so forth. But we also need to move further upstream. We need to think of how can we help the next generation, and how can we help the next generation by improving the lives of their parents. How can we develop strong communities that reduce the burdens of adversity? So early childhood interventions, we want to start early, is an important place. We have examples of great programs like the Carolina Abecedarian Project in Chapel Hill, North Carolina, took poor kids, 80% of them African American, randomized them at birth to an early childhood enhancement program and to a control group. They've now been followed to their mid-30s. In their mid-30s, those who got this early childhood program do better on a broad range of risk factors for cardiovascular disease and metabolic disease. So for example, markedly lower rates of metabolic syndrome. I'm giving you an example of the systolic blood pressure differences, 143 in the controls versus 126 in the treatment group in the mid-30s, linked to just what happened birth through 5. The foundations of health in adulthood are laid in childhood. We also need to make policy decisions. The U.S. ranks 34th in the world on child poverty, according to the UNICEF report. And it also shows that the U.S. ranking reflects the policy choices we make. So they show other societies before taxes and transfers. That's what the child poverty, the normal society produces, 42% in Ireland. After taxes and transfers reflects the preferences, the policies, the will of the people and their leaders. It's reduced from 42% to 8%. So in reality, it's only 8%, although it started out at 42%. You could see in Hungary, in Australia, New Zealand, in Canada. Look at the United States. The naturally occurring childhood poverty, 24%. After policies and transfers, it's reduced 1 percentage point. It reflects choices we are making as a society. We can make a different set of choices and produce a different set of outcomes. What do we really value is what I'm saying. In 2014, the top 25 hedge fund managers in the United States earned more than all kindergarten teachers in the U.S. combined. 158,000 kindergarten teachers earned less global total salary than 25 top hedge fund managers. What do we value as a society, and what are we willing to support? What else do we need to do? We need to enhance neighborhood and housing quality to improve health. There are examples of experimental studies that shows take public housing residents, just move them to housing with less poverty. 2 years later, better overall health, less substance abuse, less neighborhood disorder, greater satisfaction with services, higher rates of employment, lower welfare use. All you did was move them. No health intervention. Even more striking, the Move into Opportunity program. Again, public housing residents moved to better housing. 10 to 15 years later, lower levels of obesity, lower levels of severe obesity, lower diabetes risk. No health intervention. All we did was change the housing environment. Purpose-built communities is an example of a program started in Atlanta, now exists in multiple other communities in the United States, that shows the key is to address all of the challenges faced by disadvantaged communities simultaneously. We tend to do piecemeal work. But if we do it all together, look at the dramatic transformation in purpose-built communities. When they started in East Lake in 1995, crime, 18 times the national rate. 90% of residents were victims of a felony every year. Huge drug trade, 100% public housing, high rates of welfare. One of the worst performing schools in Georgia. Look at purpose-built communities today. 73% reduction in crime, 90% in violent crime, 50% public housing, 50% mixed income. All able-bodied persons are working who are low income. It's now the best performing school in the Atlanta School District, or among the best performing schools in the Atlanta School District. Dramatic transformation in a community shows us it's possible. We know what to do. We also need to improve economic well-being. If you give poor people money and do nothing else, their health improves. There's high-quality randomized studies that show this. I should correct that. Giving poor women money leads to improvement it's true. Giving poor women money leads to improvement in health. In the last 60 years, we have seen when the black-white gap in income narrowed, the black-white gap in health narrowed. So look, between 1968 and 78, the period of the dramatic narrowing of the black-white gap in the last 60 years, we had the health of whites. This is overall mortality for men. This is here, it is in 1968 and in 1978 for white males. So you could see the difference in the decline. The change for black men was larger than for white men, and percentage-wise, the change for blacks was larger. Among women, you see the same thing, a bigger change for African-American women and the decline in mortality than there was for white men, and absolutely even bigger change in terms of the relative change. So all that was done was improving economic well-being linked to improving health. I want to close by talking about one other point that we really need to think about as a nation. It is not enough to open the doors of opportunity, which as a nation we have done, but haven't prepared individuals to walk through the doors. Let me give an example that's close to home. How well has affirmative action worked in the United States for women and minorities? And it's important to remember that affirmative action was for women and minorities. It has worked much better for women and minorities. So the biggest beneficiaries of affirmative action in the United States have been whites. because most of the women have been white, yet whites show the greatest opposition to affirmative action policies. This is a percentage of women, female graduates from medical school 1965. Look at the wonderful dramatic transformation, 2010, 48% from 6.9%. Here is the change for minorities. See, blacks were around 3%, just around 6 point something percent, and Latinos just about the same place. Here's the Native Americans just scraping at the bottom here. Not much. Asians have had the biggest increase. The different success and outcomes for women versus minorities highlights the critical need of making investments to ensure that all are able to take advantage of the new opportunities. It's what President Johnson called the shackled runner. You can't put someone at the beginning of a race and have their legs shackled and then say because you've put them at the starting line, they are free to run with others who've been training for a long time. And how big is this problem? In 2014, AMC issued a report. There were 27 fewer African-American males in the first year of medical school in 2014 than in 1978. And if we look at the total physicians in the mid-1960s, 2.9% of all practicing physicians in the U.S. were black. In 2012, 3.8% of all practicing physicians in the U.S. are black. Now, the total number of physicians is up, but as a percentage, we haven't made much progress. My students think we've made remarkable progress. We haven't made as much progress as we have. And I'm saying we need to ensure that everyone can walk through the gates. And remember these words of Thomas Jefferson: there's nothing so unfair as the equal treatment of unequal people. Stop and think about that. I have shown you dramatically unequal people based on race. If we treat them equally, that is the height of unfairness. Big questions. How do we bring these interventions to scale? What's the optimal timing and sequencing of these interventions to have maximum impact? How do we understand differential effects of some of these interventions? And most profoundly, if we will reduce inequalities in health, we have to figure out strategies that enable the disadvantaged to improve more rapidly than the rest of the population so we can narrow the gap. Because if we just have everyone improve by the same rate, we will maintain. In fact, for tobacco smoking, and I have the data on it, the disparities today by education are larger than they were in 1960 or 1970. Because everybody has reduced their smoking rates, but the highly educated have reduced them much more rapidly than everybody else. So we've improved health, we've improved this risk behavior, but widened the gap. What are the keys to success? Putting the perspective of health into all policy making, building a lens of health equity to everything we do, ensuring cross-sectoral collaborations. Medicine can't do this by themselves. Allied health professions can't do this by themselves. Have data, build community capacity to make these choices. All policy that affects health is health policy. Inequalities in health didn't just happen. They reflect policies. We need political will and a commitment to new strategies to improve living and working conditions. We need to work collaboratively. We need more research, but our biggest need is to use all the knowledge that we have. Martin Luther King said, true compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. There's a lot that needs restructuring in our communities, and I wish that each one of you will follow the words of Robert Kennedy, because he said, every time a man or woman stands up for an ideal or acts to improve the lot of others or strikes out against injustice, he sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. We can start that current here today. And it's my wish, my desire, my prayer that all of you will be part of this tiny ripple of hope that will make a difference. And it begins by voting, but that can make a difference in changing the direction of this society. Thank you very much.
So are there any questions?
See a hand.
You talk loud.
hometown.
Okay.
In all of these talks, we tend to speak of black versus white or Native American versus white. I'm wondering about my children are of mixed race. Is there any data out there to suggest, or is there any data out there looking at mixed race children, with America being a melting pot and, mixed race of whatever have you, Asian versus African American and white? Is there any data looking at mixed race folks with these same data points?
So let me say a couple things. One is, it's only recently that America is systematically collecting mixed race data. One, two, the population, the percentage of the American population that identifies as mixed race is just different than the percentage of American population that is mixed race. The percentage of American population that identifies as mixed race is still low. It's still only about 5% in the last census. So you're looking at a very small population. So there hasn't been a ton of studies. There are two things we know. I had a student who recently did a dissertation looking at mixed race. The mixed race population, mental health, defined psychiatric disorders were our outcome, have the highest rates of psychiatric disorder in the U.S. Of the other racial ethnic groups, which was blacks, whites, Latinos were the other major racial ethnic groups looked at, mixed race. And the mixed race group that had even the highest rate was the combination of white American Indian, which you look within all the mixed race, it was the white American Indian combination that was the most disadvantaged. The other point we know, it doesn't matter how you identify racially. It's how you are perceived societally. It's the driver of health. So we have studies of mixed race people and ask them, do most people see you? How do most people see you? And persons who are Latino and are perceived as white, there was no health disparities in this study done by Tamara Jones. Persons who were Native American were perceived as white, there were no health disparities. But those who were Native American, perceived as Native American, there was a health disparity. Those who were Latino, perceived as Latino, there was a health disparity. So what the research suggests, it's race matters because of how society responds to you. It's not about your biology. The fact that you and I know what race it belongs to tells us more about our society than about our biological makeup. So race is a social construct, so it's how your kids are socially perceived that is going to be the driver of how society responds to them. But I agree with you, we need more work looking at all populations, looking at the heterogeneity of all populations, looking at subgroups, including the mixed race group. I saw a hand in the front.
And I always love hearing you speak. One question that I have, that it's a small point, but I was intrigued by the study that showed that the amount of pain medication was a lot less for those who were Hispanic versus those who were white with broken bones. One question that I have is, did he also control for what was asked for? Everyone's pain perception can be different.
Great question. So let me say a couple things about that. Number one, do not focus on pain medication. I just picked that at the time of the Institute of America, one of 200 different peer-reviewed published papers. In 80% of them, this occurs. It's best documented in the treatment of cardiovascular disease in the United States. No. But I want everyone to understand, this is not about pain medication. I just picked an example of pain medication, but it's documented in every single area of medicine. So whatever explanation we need to come up with has to be generic across all dimensions of medicine. This is documented, best documented in most studies in the area of treatment of cardiovascular disease. So that's point number one. Point number two, Dr. Todd did do a second study at UCLA. He wondered, could it be, didn't ask patients because he was using the medical record. The medical record doesn't have what the patient asked for. He asked the question, could it be that Latino patients are expressing their pain in a distinctive cultural manner that the providers are just not cluing in on? And so he had a group of patients to report the pain they were in, and had a group of health providers to look at them and report the pain they thought the patient were in, and found that physicians could equally detect the severity of pain in Latino patients as in white patients. So that differential perception of pain was of provider, the cultural explanation was not the driver of the patterns that were observed. But keep in mind, it's not about pain. It's true across all areas of medicine.
Thank you for your comments, for presentation. So much in such a short period of time. I'd like for you to comment on the literature as relates to health consequences of internalized racism. Sometimes people don't talk about it in that way.
Okay, so the question, I don't know if everyone heard of health consequences of internalized racism. I talk about it, but it's, you can't talk about everything. I teach a course in this area all semester long. So there's a lot of material I haven't covered, but I have papers that cover everything. No, this is true. This is really true. There are papers that cover everything. So internalized, I remember I said I talked about 2 mechanisms of racism. There are multiple other mechanisms I didn't talk about. Internalized racism is one. Internalized racism goes back to Gordon Allport in 1954, wrote a book of Prejudice, said that one response of a stigmatized non-dominant group is to accept as true the society's negative characterization of the group. And in fact, I showed you, I stated the statistic that 30% of blacks have accepted the negative stereotypes. There are studies by Jerome Taylor at the University of Pittsburgh, who has devoted his career to studying internalized racism. There are studies by Yin Paradis from Australia. Both of them find that a third of African Americans in the U.S., in Australia, a third of Aboriginals score high on scales of internalized racism. So it's not a rare thing. This 1/3 number shows up in many different places. What does the research show? That internalized racism leads to negative mental health, higher rates of psychological distress, of depressive symptoms, of substance use and abuse. There's work by Tull, T-U-L-L, and colleagues that have done work looking at the relationship between internalized racism and obesity in African Americans in the United States, black people in the Caribbean, and black people in Africa, and find internalized racism predicts elevated risk of obesity in all those 3 contexts. So internalized racism, I would say the literature, it has not been studied as much as there's many fewer studies than in the area of discrimination, but it is an important mechanism. Let me also give you one other quick example because it's stunning and it illustrates both points. Stereotype threat. Stereotype threat is a phenomenon identified by Claude Steele, a psychologist at Michigan, Stanford, Columbia, Berkeley, currently. What he showed, he would take black undergraduate students at University of Michigan or Stanford, good enough to get into these elite schools, randomize them into 2 groups. One group told, take this test. The other group told, take the test. But blacks do worse in the test than whites. The group told that blacks do worse in the test did worse on the test than the control group. He's replicated the effect among white women. If white women are brought in and half are told take the test, the other half is told women do worse than men on the test. The group told that women do worse does worse. He's replicated among white males, telling one group of white males, whites do worse than Asians on the test. That group does worse than the other group. What it takes to produce the effect, though, there has to be the larger negative stereotype in the culture. So among women, for example, the test he used was the quantitative section of the GRE. If you use a test of verbal skills, doesn't work because the stereotype is women outperform men on verbal skills. So it has to be in an area of stereotype vulnerability. And the effect is so strong among blacks, he can produce it simply by telling one group of blacks, write your race at the top of the paper before you start the test. Just recording their race before they start the test leads to poorer performance. He did it in New York, he and his students, with a group of black Caribbean immigrants. Black Caribbean immigrants, they weren't raised in the United States, haven't bought into the stereotype. They were told blacks do worse on the test. The group told blacks do worse, did better. They outperformed the other group because that's not me, However, he then did it on the children of black Caribbean immigrants. So their parents are immigrants, but they were born and raised in the United States. They've got all the socialization. They did worse when told that blacks do worse on the test. So it clearly shows what matters is the stereotype in the culture that's in your mind, and if you subtly tap into it simply by saying, right, record your race, leads to poorer performance. There are strategies, by the way, values affirmation strategies, I don't have time to describe them, that have shown profound effects in reducing these effects of stereotype threat and in improving health. There's an annual review of psychology review paper on values affirmation interventions I would suggest everyone could read. Yes.
Dr. Williams, thank you very much. Your presentation was extremely informative. And as you said, the constant stress of racism and cultural oppression leads to lower performance. And as you probably know, the prefrontal cortex of youngsters, they're constantly exposed to violence, and that's why they have the so-called behavioral problems. My question is this: for the emerging young people, like young Asian people coming over, East Indian, I understand, and you can verify this, there is a study that shows that the suicide rates amongst those young people coming over who may be torn between two cultures is rising. And I've heard about it, but I don't have any evidence. Would you be able to?
I can, because I don't know. So if I don't know, I say I don't know. I know the suicide rate is rising among young African Americans. African Americans for 100 years have had lower suicide rates than whites. They still do, but the suicide rates are rising among young African Americans, and it's rising more among young African Americans who are middle class than it is among the young African Americans who are poor. So it's not the most disadvantaged where we're seeing the increases. It's among the middle class there's a bigger increase. But I don't know. But that information is knowable, but I don't know the answer to it. Yes. Last question here.
Thank you so much for the presentation. At the beginning, you pointed out that there was this. Thank you for the presentation. At the beginning, you pointed out that there was the big gap in white health when you
Yes.
compare them around the world.
Yes.
We also know that policies get what they are intended to get.
Exactly.
We also know that the drivers of policy are in general the Caucasian community. And so therefore, if we are to see change, could we make it clearer that the health status of white people is as much at risk as a function of the sickness of our society? I don't know if it's just discrimination, but clearly when you compare white health in the U.S. with white health around the world, they're not doing well. So what is that, and how could we change it?
You're very good. It's racism. There's work. There's sociologists. Jill Quadagno is one. Scott Spoll is another, who have done research showing that much social policy decisions in Congress, the votes that have been taken going back to the 1930s, are heavily linked to concerns about who will benefit from these policies. There's scientific research, I've reviewed some of it in one of my papers, showing that much of the opposition to Obamacare was linked to the perception of many in this society that Obamacare is a program that's helping blacks, and shows there were 20% more Americans opposing Obamacare that opposed the Clinton healthcare plan. And the driver of it was the perception this is helping blacks. So if you look at the work of, I'm blocking on her name, the Dean of Public Health at UCLA has done the most work looking at various social policies, family-friendly policies. Jody Hyman is whose name I was not remembering for a quick second. Jody Hyman's work showing the U.S. ranks at the bottom of the industrialized world on every policy that supports the family, whether it's family leave or any work protective policies. Many of those policies, historically, there's work showing, have not been voted in this country because of racial prejudice. And yes, those are hurting all of us. And because it's important to remember, there are more, I've told about the power of socioeconomic status. There are more poor white people in this country than poor African Americans. There are more poor white people in this country than poor Latinos. Latino minorities have higher percentage of poor people, but the majority, if you look at who are the poor numerically, is white people. So the white community has been hurt by short-sighted policies, and they have also been hurt by politicians who have played the race card and had them vote against their own economic interests, instead voting for their racial interests. So yes, I think we need to find ways, Mr. Good note to end on. One of the big challenges we face is how to tell the story of the plight of the disadvantaged in a way that connects. And how can we find ways to communicate effectively with the population of some of these challenges that shows everyone it is in all of our interests when we improve the health of all. You know, and one of the points I make on the last point, in 2060, come with me to 2060 or 2050 in the United States, the majority of people on Social Security will be white. 66% is estimated will be white. For every one person on receiving Social Security, there will be 2 people working. One of those 2 paying into the system will be black or Latino. Those black and Latino kids are in kindergarten today. If you want Social Security to be a stable, financially viable program that will be there when the time comes for you to receive your retirement, anything you can do today to ensure that those minority kids get the best education, have the right skills, can get the right jobs to be productive and pay into the system, it's in our personal economic interest. Thank you.